This is Lauren Dunlap, Executive Director and Co-Founder for Advocacy and Awareness for Immune Disorders Association, or AAIDA, in Charlotte, North Carolina, and I am so pleased to host today's webinar. AAIDA's mission is to advocate for patients living with primary immune deficiency, secondary immune deficiency, and autoimmune diseases, and to create awareness and conduct research to find cures for these different groups of diseases. I would like to take time to thank our friends at Allergy and Asthma Network for their continued support and involvement with AAIDA. And I would also like to thank our sponsor for this educational webinar, Amgen, for making educational webinars such as this possible for patients and others in the community. This is AAIDA's second educational webinar during 2020, and we're joined tonight by Dr. Delfin Santos, who will be speaking on exploring the clinical understanding of Behcets disease. Dr. Santos has been in private practice for 28 years and currently serves as director of AARA Rochester Rheumatology Center in Rochester Hills, Michigan. He is on the teaching staff of the Wayne State University Internal Medicine, Family Practice, and Transitional Residency programs. Dr. Santos earned his medical degree from UCMM in Santiago, Dominican Republic, and he completed his internal medicine residency program at West Suburban Hospital Medical Center in Oak Park, Illinois, where he was chief resident. Dr. Santos completed his fellowship in rheumatology at Rush Presbyterian St. Luke's Medical Center in Chicago, Illinois, and served as chief of the Department of Medicine and as vice chief of staff at Ascension Hospital Medical Center in Rochester Hills, Michigan. Dr. Santos is a consultant in rheumatology at Beaumont Hospital and at Ascension Hospital Medical Center, is the rheumatology consultant for the Michigan Department of Correction, and is a consultant on the Speakers Bureau for various pharmaceutical companies. Dr. Santos has been on the advisory board for the American Behcets Disease Association for the last 20 years and is repeatedly named top doc in rheumatology and Our Magazine Detroit. Thank you so much, Dr. Santos, for being here with us today to wrap up Behcets Awareness Month. Dr. Santos, please proceed.
Yeah, good evening, everyone, and thank you for allowing me to do this. I want to thank Advocacy and Awareness for Immune Disorders Association for allowing me to do this, and thank Lauren Dunlap and the American Behcets Disease Association, who's I've been working with for a long time and has helped kind of put together some of this. Today, what I'd like to do is talk about Behcets disease, and it's going to be kind of in steps. I want everybody to get a good understanding of exactly what Behcets disease is, because it's a rare disease and it's not something that we see a lot of. In fact, what's interesting is that there are a lot of doctors out there that I talk to that say, well, I've heard about it in medical school, but I don't know what it is, and they don't know the specifics about it. And one of the things we want to do is really get the word out there that what the disease is and how to make the diagnosis. This is my disclosure. I'm not getting paid to do this lecture. This is voluntary, and but I put that on there in case anyone wants to know about any interest or any problems with the lecture, which there won't be. So Behcets is interesting because it was really described back in BC by Hippocrates. And he described this endemic disease in Asia Minor that was characterized by aphthous ulcerations, defluxions about the genital parts, watery ophthalmies of chronic character, which destroyed the sights of many persons, and large herpetic lesions. And that's basically, in a nutshell, that's what Behcets is. Now, a little bit more history, because Benedictos Amantadides is the first person in modern era that kind of described a case of Behcets in 1930, when he presented a 29-year-old man with relapsing iritis, which is inflammation of the eyes with hypopyon. In his paper, he described the classic manifestations of Behcets with oral ulcers and genital ulcers. Some people call this condition Amantadides Behcets disease because of Benedicto's input, but we know it really as Behcets disease because of Ulysses Behcet, who was a Turkish dermatologist and a scientist, and he described the triple symptom complex in 1937 with the aphthous ulcerations, genital ulcers, and the inflammation of the eye. And so because of his contribution to the disease, and he presented at many conferences, we now know this condition mostly as Behcet's disease. So what is Behcet's disease? And it's interesting because there's a lot of different opinions. Is this an autoimmune disease? Is it an auto-inflammatory disease? Most autoimmune diseases we can test, and there are blood tests, autoantibodies, ANAs, and different blood tests that we can use to diagnose things like lupus and rheumatoid arthritis and other forms of autoimmune diseases. There's no such thing with Behcet's disease, and many of us characterize it as an auto-inflammatory disease. And the immune system is a little bit different. The innate immune system is more responsible versus the humoral immune system, but I won't get into the technicalities of that. So it is a rare multi-system systemic vasculitis. Vasculitis is an inflammatory condition of blood vessels. And the disease is characterized by what I previously mentioned, oral and genital ulcers with eye involvement. There's certainly other manifestations. There's a lot of skin manifestations with ulcerations, acne type changes in areas other than the face, arthritis, inflammation of the bowel, neurologic symptoms, and thrombophlebitis, where there's involvement of the vascular system. So depending upon where one lives, there's a different prevalence of disease, and I'll talk a little bit about why that is, because genetics does play a role in this condition. You can see that the country in the world that has the most cases is Turkey, anywhere from 370 to 420 per 100,000. So taking the population of Turkey, which is approximately 82 million people, we get a number of about 340 patients in the country. Iran is a similar sized country to Turkey. They have about 82 million people, but their prevalence is about 80 per 100,000, so they have about 65,000 people. If you look down the list there and look at the United States, our incidence of Behcet's disease is much smaller, and it's been calculated to be around 5.2 per 100,000. We calculate anywhere from 16 to 20,000 patients in the United States with this disease, and that's why it's considered a rare disease. Now, as I mentioned, genetics does play a role, and if you look at Germany, which is down by the bottom, it's calculated to be about 2.26 per 100,000. But when you look at German patients with Turkish descent, that number goes up to 77.3 per 100,000. And if you look at patients with Lebanese descent, that number is up to 101.3. So I'll talk a little bit about the genetics and the major causes of Behcet's disease. So comparing Behcet's to other diseases that we see in the United States or around the country or around the world, you can see that osteoarthritis affects 68 million Americans. Gout affects about 8.3 million Americans, and rheumatoid arthritis about 1.3 million. So when we talk about 16 to 20,000 with Behcet's, you can see how it's a much less common and more rare disease. Even lupus, which is not as common as the other conditions, is still, we see anywhere from 160 to 320,000 patients in the United States. So geographical variation really depends on genetics. And this slide here, what it shows is it shows a map of the world, and I've superimposed the Silk Road, which is an area from the eastern shore of the Mediterranean that extends out towards Japan. And this is an area that used to be something that many people would travel for trade, and silk was traded down this route, and that's why it's called the Silk Road. And this is where most of the cases of Behcet's occurred, and there's a lot of theory as to why this is. So Behcet's disease, I mentioned, has a genetic factor, and we know that there are these MHC class 1 region genes, and the most commonly known is the HLA-B51 that is seen in over 50% of patients in Turkey associated with Behcets. Less than 20 to 25% of patients in the United States are going to have the HLA-B51 gene. It isn't exclusively seen in Behcet's disease. It can be seen in other conditions, and I'll show you some examples in a minute. But we also know that there are also non-HLA regions, so other genes play a role in the development of Behcet's disease. And there's been some recent studies isolating IL-10, IL-23 receptor, and IL-12 receptor B2. The fact that there's a high concordance with monozygotic twins, so twins that are from the same egg, it shows that this is a genetic condition. So this study was done in New Mexico, and it's interesting. It was presented at the 2015 American College of Rheumatology. The study was done by Salayandia et al. And what they did was they just, in their rheumatology clinic, they screened 1,200 patients with autoimmune, the first 1,200 patients coming through, and they did an HLA-B51 on them. So whatever the patient was, they did an HLA-B51, and they found that just screening patients that were B51 positive, about 14 of these patients met the criteria for Behcet's disease, so about 25%. But 31% had other autoimmune diseases, and it's broken down underneath: 10.9 systemic lupus, 3.6 rheumatoid, and so on. So there were actually more patients that didn't have Behcet's that were HLA-B51 positive that had other autoimmune diseases as a group than with Behcet's. Most of these patients were Hispanic, I think over 60%. And so this doesn't necessarily mimic what we see in the rest of the United States, but it is interesting to see that HLA-B51 in the United States is prevalent, but it's not enough to necessarily order it in every patient that you suspect Behcet's disease. If you have a diagnosis of Behcet's, I will do the HLA-B51. It can be helpful. Sometimes some of the manifestations might be a little bit more severe, but for screening, it really doesn't help you. So there are other factors that play a role in the development of Behcet's disease, and forever we've been trying to find out what is the cause. We know, or we think, that there are microbial agents, possibly bacteria or some type of virus that could be predisposing to this, and strep has been looked at, herpes, tuberculosis has been looked at, but none of these have been definitively felt to be the cause of this condition. They may play a role. There are actually clinical studies where in the labs they're trying to design mouse models of Behcet's, and some of them they're doing it by stimulating these mice with herpes virus, and many of them develop many of the symptoms that we see with Behcet's disease. But low socioeconomic status seems to be associated with the higher incidence of Behcet's and pollution. So I'm not going to get into the technicality of this slide. This is just to show that there are many proteins in the body that cause inflammation, and a lot of these same proteins are found in other autoimmune diseases, rheumatoid arthritis, lupus, psoriatic arthritis, and these are also found and cause inflammation in Behcet's disease. So there are different ways to diagnose Behcet's. Remember, I said there's no blood test that's going to diagnose the condition. And because of that, it makes it harder for people to diagnose it if they don't know what Behcet's is. Many doctors, as I mentioned, aren't familiar with the condition. So they've developed criteria to diagnose the disease. And this is one of the criteria. I'm gonna mention two because they're a little bit different. This one, the International Study Group criteria, was developed in 1991, and it basically says that all patients have to have oral ulcers to be included in the criteria. And many of you that do suffer from Behcets know that not everyone has oral ulcers. But in addition to the ulcers, you have to have two of the following. You either have to have recurrent genital ulcers, eye lesions, skin lesions, or pathergy, which is, I'll show you a picture. It's where you prick the skin with a needle and you get a little papule or pustule, like a little a pimple at the site of the needle puncture. So this one is actually a little bit more specific than the other criteria. This is the international criteria for Behcets disease. And I show this because for years, being involved in the American Behcets Disease Association advisory board, I get referrals from doctors for patients that didn't quite meet the international study group criteria. So they might have oral ulcers and genital ulcers, and that's it. And those patients that had those two would not meet the international study group criteria, but they do meet the international criteria for Behcets disease. And you can see here that you really need to get to 4 points or more. And oral ulcers and genital ulcers are 2 points apiece. Now, it's important to keep in mind that there are other conditions that can cause these ulcers, and we have to make sure we're not diagnosing patients with Behcets that have, for example, Crohn's disease or some type of infection, herpes or something where they might have these lesions. So you have to exclude other things. The most common age where Behcets occurs is around the second and third decades of life. Pediatric cases are well documented, although they're not that common, but they're certainly out there. And diagnosing somebody with new onset Behcets disease is pretty rare after the age of 50. And I tell my colleagues when I'm talking about this to the medical community, if you see a 55 or 60-year-old person with oral and genital ulcers, Behcets is not the first thing that you think about. And I'm not saying it can't occur, but it is quite uncommon. So these are the clinical manifestations of Behcets disease, and you can see it affects a lot of different organ systems. But the most common, oral ulcers, 95 to 100%. It can affect the eyes, the GI tract. And what's interesting is there is variation in where you live. So, for example, in Turkey, the GI symptoms are not as prevalent as they are in the United States. If you look at the eye problems are more common in the Middle East and Turkey than they are in the United States. But the other manifestations, the joint pains and the skin lesions and the genital lesions are pretty similar in most places. So there are other criteria. I mentioned the major criteria, which would be the oral, genital ulcers, the eye problems, and the skin lesions. The minor criteria are arthritis, vasculitis, the GI tract, cardiovascular lesions, neurologic lesions, and I'll talk a little bit more of each one of these as the lecture goes on. So oral ulcers, these are lesions that occur 95 to 100% of the time. They are not distinct to Behcets disease. If you biopsy one of these lesions, you're not going to find anything other than what we would see with your common aphthous ulceration, people that get mouth sores. And they vary in size from 1 to 3 centimeters. They can be very large. Sometimes they can scar in the mouth. They can be unique or they can be multiple, and usually they heal within 1 to 3 weeks. So these are pictured right here. This is a large ulceration, and you always have to make sure, as I said, that it's not something else, because other conditions can mimic these pictures. And there's another lesion on the left there, and these, by the way, are very painful. People have imagine having multiple lesions of these where people lose weight, and it really affects their ability to function. I know some doctors who have recurrent oral ulcers don't have Behcets, but that have a hard time even speaking in public because of the pain that these provide. So here's somebody with a lesion on the lip and also multiple lesions on the tongue. So other conditions that you have to be aware of. So herpes is different. I'll show you a picture of herpes oral lesions in a minute, but other conditions, inflammatory bowel disease, lupus can cause mouth sores. drugs that we use commonly for autoimmune diseases, methotrexate. And then there are other dermatologic conditions, pemphigus, and even people with lymphomas or myelodysplasia, which are hematologic problems, can present with recurrent mouth sores. So this is a patient with oral herpes. The Behcets does not involve the skin of the lip, and if you get things that are over the fold or onto the skin, that's not what we see with Behcets disease. So this is a herpes lesion, pretty classic herpes lesion. The genital ulcers of Behcets are very common, as I mentioned, and they primarily occur in the vulva, also on the penis, on the scrotum of the males. They could and have been reported to occur inside the vagina, but the nerve endings inside the vagina are not as prevalent as they are on the outside, and so many times inside the vagina they would be asymptomatic, but they're much more painful on the outside over the vulva and certainly on the scrotum of males. Differential diagnosis of genital ulcers, viral conditions, bacterial conditions, reactive genital ulcers which just occur due to trauma or unknown reasons. Certainly Crohn's disease, lupus can do it. A lot of the drugs I mentioned can also cause vaginal ulcers, and even malignancies can do it. At the top, viral, I get a lot of patients referred to me for evaluation of possible Behcets disease, and so I see a lot of things that aren't Behcets disease. I saw a young lady last year that had a history of a very painful vaginal ulcer, and this young lady was not sexually active, never had been, and had mouth sores also. And she ended up having an Epstein-Barr virus. We call it Vulcus vulvae accutum. And it's a very, very painful, isolated lesion. It's usually a one-time thing, but it can, as you see, can cause oral and genital ulcers. And her serology for Epstein-Barr was quite high, and so the diagnosis was confirmed. So a little bit about eyes. The eyes occur in about 50% of patients. It could be bilateral, usually bilateral, but sometimes it could be unilateral. There's sometimes no resolution between episodes, and it's always good to have a good ophthalmologist on the team. We have a good one here in Michigan who actually trained at NIH, and so we consult with her frequently. Hypopyon, and I'll show you a picture of this, is when you get a lot of white cells build up in the eye, and then they kind of pool at the bottom because they settle in the eye. And uveitis can be anterior, which is the least problematic one, but it can be posterior or panuveitis, which could actually lead to blindness. Retinal vasculitis is something, a lot of these conditions can cause blindness, and so really important to have this evaluated. Here's a picture of acute iritis, and this is anterior iritis, and you can see all those little polka dots in there are really white cells that accumulate. And after a while, if you can see here, that these, and I'll show you a little, I'll point to it if you guys can see right here, is we call that a hypopyon, and it's just like a pus layer on the bottom of the eye. And imagine all the inflammation that's occurring in that eye and the possibility of losing vision because of this. So other causes of uveitis, and I keep showing you other causes of these conditions because it's really important to make sure we're making the right diagnosis. You don't want to diagnose somebody with Behcets and they turn out to have some type of bacterial disease or some type of other autoimmune disease that's going to lead to problems that you're not expecting. But a lot of autoimmune diseases, sarcoid, inflammatory bowel disease, all of those are possible. A lot of infections, and you can see that a lot of the conditions that are associated with uveitis are also seen in patients who have genital ulcers or patients that have oral ulcers. So there's a lot of overlap. But even parasitic lesions can involve the eye. and it's good to get a good eye evaluation. The skin involvement with Behcet's disease, it's frequent, anywhere from 40 to 97%, and frequently it's as simple as having acne type lesions on areas other than the face, as long as it's not a teenager or somebody who is on steroids, for example, where the pustular lesions are more common. But this does occur in about 64% of patients in the United States. These are what we call folliculitis. There's also what we call erythema nodosum. An erythema nodosum is an inflammation underneath the skin, where it's almost like a nodule, and it can be multiple lesions or singular lesions. Now, again, when we talk about erythema nodosum, there are a lot of conditions associated with it. And as I mentioned, some of these, like inflammatory bowel disease, are also associated with uveitis, oral ulcers, sometimes genital ulcers. So a lot of overlap, and you have to make sure. You certainly don't want to miss a lymphoma in somebody who presents with erythema nodosum and you're diagnosing them with something else. There are many drugs associated with erythema nodosum, and these are drugs that are commonly used. I'll mention a couple here. Minocycline. Minocycline is a drug that's used for acne. And not only can you get erythema nodosum with minocycline, but I've seen many cases of drug-induced lupus. And these are generally younger patients that have been treated for a couple of years with minocycline to try to prevent their acne. And I'll see them complaining of joint pains, sometimes skin rashes, and they'll have a high ANA. And basically the treatment is to stop the minocycline and it goes away. But other drugs, you see salicylate, so aspirin sometimes can cause erythema nodosum, and certainly sulfa drugs and penicillin and oral contraceptives. And I've seen erythema nodosum when women on birth control pills. So we always have to look at what drugs people are on before we confirm that this is Behcet's disease. And then infections, and again, a lot of different bacterial infections, fungal infections. So we just have to, the doctors have to be aware of this. This is what I was talking about earlier, which is the pathergy test. And there's even some debate between rheumatologists and some of the experts in Behcet's disease as to what is a positive pathergy test. I think you take a 25 gauge needle and you prick the skin, and if you get a nodule, and you can see here that after a few days, usually 48 hours, you get a little nodule that forms. I think this most people would say this is a positive pathergy test. Some physicians feel there needs to be a little pustule, so a little pimple at the tip, but not everybody feels that that's necessary. So this is very uncommon in the United States. I've only seen 2 patients out of my group in the United States have this. It's much more common in Turkey and in the Middle East. So some of the associated problems with Behcet's, we know that for the most part, when I talk to a patient about Behcet's disease, I'm telling them that they have symptoms that are going to be uncomfortable, painful, but most people with Behcet's don't have to worry about dying from their disease, but there's a small percentage that do, and those are the ones that develop neurologic problems or vascular lesions. And the neurologic problems can be thrombosis of the central sinus. They can be problems involving the arteries that supply the brain and cut off blood flow, aseptic meningitis and meningoencephalitis, and these patients have to be treated with high-dose steroids to control their symptoms. They can get confused, memory loss, insomnia, somnolence, a whole bunch of different symptoms, mental confusion, and it can really be a serious problem. And this is one of the conditions that could certainly cause early death. The vascular problems can occur. I mentioned the central sinus, which is a vascular problem, but patients will get deep vein thromboses, get aneurysms, and you can see here this is an aneurysm of the femoral vein, pretty large aneurysm, and these can rupture. They can be very problematic, and if they occur in the heart and the lungs in different areas, and they're undiagnosed, they can lead to significant morbidity. Now, what's interesting about deep vein thrombosis and Behcet's disease is it's not your typical cause. People that get deep vein thromboses that don't have Behcet's go to the hospital, they have a blood clot in their leg, they get put on blood thinners. Patients with Behcet's get these blood clots because of this intense inflammation in their vascular system. And so the main treatment is not blood thinners, it's really immunosuppressive drugs and steroids to reduce the inflammation around the artery. Now, if I talk to an emergency room doctor and they have a patient with a blood clot in their leg, and I tell them don't put them on anticoagulation, I'm going to have a hard time convincing them because that's the routine thing they do, and they're worried about these clots going up into the heart. I can tell you that the most important thing I tell them is to get a CT scan of the chest and make sure they don't have an aneurysm. And if they don't and they wish to anticoagulate, that's fine, but I also want them on steroids. So the arthritis with Behcet's, we see it in 40 to 70% of people. This is generally a non-destructive arthropathy, and what that means is we don't get the erosions and the damage that occurs in rheumatoid or some of the other forms of arthritis, but it can certainly be very painful. If we take fluid out of the joint, it mimics the fluid we might see with rheumatoid or psoriatic arthritis. It's a lot of inflammation. It's usually the lower extremities and the knees, ankles, but also can involve the hands and wrists. Other signs and symptoms, and these are less common, but we worry about the gastrointestinal tract. We worry about the lungs and pulmonary infiltrates, and when that happens, you have to worry about blood clots. It can cause inflammation of muscle. In rare cases, it could cause peripheral gangrene if it cuts off blood flow. Inflammation of the testicle with epididymitis. Rarely will it affect the kidneys, but it has been reported. And I already talked about thromboembolic events. So this is a Behcet's syndrome activity scale. And it's a busy slide, and I apologize about it, and I don't expect you to read everything. I just want you to know about this because this is a scale that's been developed to evaluate how somebody's doing with their Behcet's disease. And so there's different questions here. You know, how many ulcers did you have in your mouth over the last 4 weeks? You know, have you had any swelling or discoloration of your extremities or a blood clot over the last 4 weeks? Some of the questions. And I put this up there to show that when we look at Behcet's disease current activity, there's a little bit of difference between what we see in the United States and what's seen abroad in Turkey, for example. We tend to have higher BSAS scores in the United States and in Turkey. And so the symptoms might be more problematic in regards to how they're perceived in the United States than what they're being perceived in Turkey, and some of that could be related to some of the manifestations that we see here. The GI tract, much more common in the United States than in Turkey, but we're not sure why that is. But those of you with Behcet's, some may be asked to fill out these questionnaires to see how your disease activity is doing from one visit to another. So as far as laboratory tests go, we really don't have any blood tests, as I mentioned. So we check a SED rate, CRP, those measure inflammation, a CBC, chemistry profile. If we think somebody has Behcet's, I'll do the HLA-B51 just to have that. But in the United States, as I mentioned, a positive or negative test doesn't really tell me whether or not somebody has the disease, and it doesn't exclude other conditions, as I previously showed you. So treatment of Behcet's, it's really based on primarily case reports. So the literature doesn't have a whole lot. And I'll talk about some of the drugs in a minute that are available to treat Behcet's, but there's very few randomized clinical trials. And so a lot of it is due to experience. And the reason is because of the few number of patients that we see in the United States, And to some degree, that's a detriment because unfortunately, these patients with Behcet's disease are looking for help, and there's not a big interest in clinical trials because of the fact that there aren't a lot of patients out there. But I think recently we've had a drug approved in the United States, and I'll talk about that. But I think that the more we research and the more we get the word out there about Behcet's disease, hopefully the more it'll pique the interest of the pharmaceutical companies and get more clinical trials to try to find other treatments that better can control this condition. So the main treatment for Behcet's initially is glucocorticoids. And as all of you know, glucocorticoid steroids have a lot of side effects. I always tell my patients, I'm going to put you on this, but I don't want to keep you on long term. Why? Because glucocorticoids have an increased risk of diabetes, cataracts, poor wound healing, osteoporosis, thinning of the skin, weight gain. I mean, the list goes on and on. And while steroids can be life-saving, they are double-edged and they can certainly cause their own set of problems. So we always try to find drugs that we call steroid-sparing agents, drugs that would do what steroids do without all the long-term steroid side effects. Colchicine is a common drug that's actually been around since the 1930s. It's interesting because about 4 years ago, the FDA took generic colchicine off the market because there was no FDA-approved indication. The drug was out there and everybody used it for gout. It was used for Behcet's disease and some other conditions for familial Mediterranean fever and other things. But there was no FDA-approved indication. So the FDA came in and said, no, we're taking it off the market. And they gave the rights to one company who brought it back. Now, where it used to cost $5 for a month's supply, now colchicine has gone up to over $200. And that's a problem that we have in this country as far as the FDA and that. But it's getting cheaper. There are some alternatives at this point, but colchicine is a drug that helps with the oral ulcers. It helps sometimes with the skin lesions. Has helped with erythema nodosum, but there are some toxicities to colchicine. Can cause diarrhea. They're actually part of the reason it was taken off by the market by the FDA is because when colchicine is used in combination with certain drugs, it can actually cause arrhythmias, irregular heartbeats. For example, patients who are on antifungal medications, patients who are on Biaxin or erythromycin antibiotics, there can be significant drug interactions with colchicine. So when I put somebody on colchicine, I'm always talking to them about talk to your doctor if you're going to go on any medication to make sure that there's no drug interactions. So this is the drug that was recently approved by the FDA for the oral ulcers of Behcet's disease. It's the only drug approved for Behcet's disease. It's the only drug that's really been clinically studied. And it's actually quite a nice drug because it's very safe and side effects are very minimal, if you will. There is diarrhea, which is about 20% of patients, but there's only 2 warnings with the drugs. One is depression in about 1% of people, and the other one, 5 to 10% of people will lose, or 10% of patients will lose 5 to 10% of their body weight. A lot of my patients like that are heavy. I get more complaints about people not losing weight. Hey doc, I'm not losing any weight. You said I was going to lose weight, and really it's only about 10% of people. So this drug is available out there, and it's nice to have. What it's really done, and I applaud. It was initially Celgene and now Amgen for bringing this drug to market because it's really gotten it out in the forefront. I was in the past working with the American Behcets Disease Association, talking to small groups of doctors about Behcets. And when I went to the speakers training on Premolast, there were over 100 doctors learning about Behcet's disease. And I think it can only be good for this condition. Other drugs, the TNF biologics, and there's 5 of them: Enbrel, Remicade, Humira, Cimzia, Simponi. These are drugs that are not FDA approved for Behcet's disease, but do work. If you remember back when I showed you all the proteins that cause inflammation in this disease, many of them are also found in things like rheumatoid arthritis and these conditions. So these drugs are targeting a protein called TNF, and they inhibit that, and that protein has been shown to be very active in Behcet's disease, and I've treated patients successfully with these drugs when we can get them approved. They're very expensive, and the insurance companies many times don't want us to use them or won't allow us to use them. Other agents, and I'm sorry about the busyness of this slide, but the other agents, and there's many: methotrexate, azathioprine, cyclosporin. These are all immunosuppressive drugs that can be tried in somebody who's more resistant. And azathioprine, the second one on the list there, is the other drug where we have peer-reviewed clinical trials that have shown efficacy in not only the skin and the oral ulcers, but also in the uveitis and in genital ulcers. Other things here down the line there at the end, magic mouthwash, for example, is used, and there's many different preparations of magic mouthwash. They're used to alleviate pain in the oral mucosa. Glyoxide is an oral solution liquid that you can get over the counter and at Walgreens or Walmart, Costco's, wherever you go. And I've had patients tell me that this really helps them with their mouth sores. Unfortunately, the mouth sores, when they're there, are very, very uncomfortable. I've had good success in some patients with colchicine. Other patients, the apremilast has worked much better, but there's still other patients that don't respond to any of those. There are clinical studies right now ongoing with pentoxifillin as a topical oral type of solution that preliminary studies suggest that there is some response there, and maybe we'll see that come to market at some point in the future. So the prognosis and clinical course really, really varies between countries. It also is very variable from patient to patient. There are exacerbations and remissions. The typical presentation is frequently with mouth sores or genital sores, but later patients can develop the other manifestations. And it's really important to remember, because part of the difficulty of diagnosing Behcet's disease is some patients will develop mouth sores and not develop other symptoms to confirm the diagnosis for months to years. And so many times I know some of my patients will get frustrated because I can't give them a definitive diagnosis, not just for Behcet's, but other autoimmune diseases. And the problem is everything doesn't show up at once. And sometimes it's just a matter of time before you can definitively confirm somebody is having this condition as well as other autoimmune type conditions. Now, mortality is low. It's estimated to be about 4%. And it's usually associated with the central nervous system, hemorrhage, for example, the vascular problems with aneurysms, or even bowel perforation that can occur sometimes. There are common causes of morbidity with Behcet's disease, and blindness is certainly one of the major issues that we have to do whatever we can to try to prevent. So I'm going to stop there and take any questions if we have time.
Thank you, Dr. Santos. So we're now going to take your questions, and I have several for you. Have you seen peripheral nerves affected?
Yes, so peripheral neuropathy is actually something we see commonly associated with many of the autoimmune and vasculitides that we see. So it's not unique to Behcet's disease. It actually happens periodically in other conditions. And one of the more common causes of peripheral neuropathy is what we call idiopathic. So we see it unrelated to any of these autoimmune diseases, but I have seen it with Behcet's disease.
Thank you. let's see. I have a diagnosis of Behcet and I'm now having neuro symptoms. What should my next step be?
Well, very important to determine what type of neurologic involvement there is with Behcet's, because central sinus thrombosis would cause severe headaches, and that requires, actually all forms of neurologic Behcet's requires a good diagnosis and aggressive treatment. So if somebody has, for example, meningoencephalitis, uh, steroids are really important because there can be some significant sequela from undiagnosed central nervous system Behcet's. The usual workup, you need a good neurologist that's familiar with the condition and a good rheumatologist to make sure that this is truly Behcet's disease. Behcet's can cause headaches that aren't associated with vascular or neurologic disease. And so not all the symptoms in somebody with Behcet's is necessary neurologic Behcet's, but it certainly has to be diagnosed.
And forgive my pronunciation on this one. And sclerosis of basal nucleus. Have you seen a red due to thrombosis of small vessels?
Well, that's been reported. And so those could be manifestations of Behcet's disease and clearly require aggressive therapy. So yes, that is something that has been reported with Behcet's. Luckily, it's not a common manifestation of Behcet's disease, and certainly involvement of the brainstem with sclerotic lesions could occur. Now, there are other conditions that could do this, and you have to rule out MS and other demyelinating conditions and make sure that you're not being diagnosed with the wrong thing.
Have you seen, again, pronunciation, apologize, Prinzmetalgia due to Behcet?
I have not, and Prinzmetal's angina is something that can occur in just the normal population. The fact that I haven't seen it doesn't mean it can't occur with Behcet's disease. It's interesting because we see individual patients that can have different manifestations, and you can certainly have two different conditions occurring in the same patient. So that's Prinzmetal's angina is not something that I would say is normal. Prinzmetal's angina is generally somebody who has chest pain with normal coronary arteries, and the problem with Prinzmetal's is not what we typically see with Behcet's, where you could have vasculitis, which is actually inflammation of the blood vessels.
I missed the section of which proteins cause the inflammation in Behcet's. Will there be a replay? And I'm going to go ahead and remind everybody that this recording will be available on the AIDA website in the next couple of days. But Dr. Santos, can you just touch briefly on that since she missed that section?
Sure, and I'm going to take you back to the slide on that because there are a whole bunch of what we call cytokines, and these cytokines are different proteins that are associated with inflammation. Let me see if I can find these. They're back a little bit further, but TNF is certainly one of them. IL-1, IL-6. These are all different types of. Here we go. Of what we call cytokines. These are proteins that are released from cells, and they go and they attach themselves to other cells, to T lymphocytes, and they cause the release of more inflammatory cells. So all these enzymes, for example, IL-2, IL-6. IL-6 is something, actually, you guys may have heard of the cytokine storm where the patients with COVID-19 are dying and they get put on ventilators from this massive inflammatory reaction. Well, this IL-6 is one of the enzymes that is associated with that massive cytokine storm. But you can see others, IL-17, IL-12. IL-12, IL-23 are commonly found in patients with psoriatic arthritis and psoriasis. or TNF, I mentioned we have those TNF inhibitors common with a lot of the inflammatory conditions. So there are more, but these are the most common.
What if I don't have oral ulcers, but all the other symptoms?
Excellent question, because if you look at the different criteria, you wouldn't be classified as having Behcets based on the International Study Group criteria. And so if we go to the international criteria for Behcets disease, you can see there are other conditions. And so if you had, for example, genital ulcers and skin lesions, that would be 3 points. You wouldn't quite meet the criteria. But if on top of that you had ocular, so you had uveitis, and there was no other explanation for why you had uveitis, that would be enough to diagnose Behcets disease. Again, remember, as long as you're excluding other conditions that could be causing the problem. So the importance of diagnosing Behcets is always excluding other conditions. And some of those other conditions, there are maybe blood tests that we can do, for example, lupus or rheumatoid arthritis, or patients maybe have inflammatory bowel disease and have Crohn's disease. You have to rule out those things. So yes, you can certainly have Behcets without the eye problems. The first patient that I ever saw with Behcets, I missed the diagnosis. The patient didn't have mouth sores. This is back in 1994, and really is what got me interested in the condition. He had vascular lesions in the chest and the skin rash, and I ended up sending him to one of the major institutions, and they diagnosed him with Behcets. I decided I better learn more about Behcets, and I didn't miss my second one. So it can occur without the oral ulcers.
Are most of the meds prescribed covered by insurance?
Most of the meds prescribed, yes. Most of the old drugs will be covered by insurance. It's hard to answer that question in the sense because there are so many different insurance plans and they have different formularies. But the traditional drugs like colchicine and methotrexate and azathioprine and cyclosporin, some of the old drugs, those generally are covered. Otezla, which is a Premolast, that's the drug that's approved for oral ulcer Behcets, should be covered. And it's a little bit easier now to get that drug because it is the only FDA approved drug for the oral ulcers of Behcets disease. People ask me, does it work for other manifestations of Behcets? And I have seen it work on the skin and in the vaginal ulcers. There's no data to support its use in uveitis or in any of the vascular lesions. The TNF drugs are quite expensive and do not get covered by insurance, unfortunately.
We have time for one more, and this one is there a predisposition to develop Behcets disease among families?
Yeah, actually there is, and that's where genetics plays a role. And I mentioned early on about the monozygotic twins are much higher likelihood of, if one has it, the other one getting it. But we also see it run in families, and this is where the genetics of HLA-B51 and the IL-10, which is a non-HLA or MHC gene. So I showed one of the slides that mentioned that the incidence of Behcets in Germany was 2.26 per 100,000. But if you look at patients with Turkish descent, it went up to 77 per 100,000. And so a lot of these are based on genetics. And so, yes, it is seen more often in family members.
Thank you, Dr. Santos, for joining us this evening. And I wanted to thank everyone for listening this evening as well. And we do hope you will join us for our next educational webinar on August 21st from 2 o'clock to 3 o'clock Eastern Standard Time with AIDA's own co-founder, Dr. Maeve O'Connor, who is a practicing allergist immunologist in Charlotte, North Carolina. And Dr. O'Connor will present PANDAS and A&E, a community discussion. And also, I wanted to take time and I realized I didn't do it earlier, thank the American Behcets Disease Association for partnering with us on this webinar. If you have any questions, do feel free to email us at info@ godoaida.org, and that's with 2 A's, or you can call us at 704-993-8389. Thank you again for joining us this evening, and we hope you have a great and healthy